All right, let's review for this quiz before we fail it. We're going to be talking about the skull, the cranial nerves, the meninges/circulation, and the brain. We have the neurocranium, made up of the frontal, ethmoid, sphenoid, and occipital, which count as unpaired for the neurocranium, and then the temporal and parietal, which count as paired because there's two of them. Kind of makes sense. And the mnemonic for the neurocranium is old people from Texas eat pickles. So occipital, parietal, frontal, temporal, ethmoid, and sphenoid. And then for the viscerocranium, we have the mandible, ethmoid, and vomer, which are unpaired. There's only one of them. And then for the paired, we have the maxilla, inferior nasal concha, zygomatic, palatine, nasal, and lacrimal. And those are paired. So the mnemonics for the neurocranium is the old people from Texas eat pickles. And old people from is, I would say, pretty good because that covers the clavaria, which is the cap. Then you have the temporal, ethmoid, and sphenoid. And again, we talk about like how neurocranium is like here, while the viscerocranium is like here. And then we go to the sutures and landmarks. So we have the coronal suture, which would be at the front right here. And then we have in the back. I don't know if you can see. I'm not flexing my fate, I promise. We have the lamboid. What do you call it? Yeah, lamboid suture. And then straight across, we have the sagittal between the parietal bones. We have the bregma, which is basically right here, this little point where those two sutures meet, the sagittal and coronal. We have the pterion, which is right here. And gotta watch out because it's the weakest point, and we can get MMA rupture, which would lead to a epidural hematoma, which we'll talk about later. Then we have the lambda, which is the point right there. And then the asterion, which is like right here between the parietal, occipital, and temporal. Then we have the frontinelles, which are basically unossified gaps for the kids. The anterior is the largest, and it's the one that they talk about the most. Usually, if you can actually feel it because it's still soft by the time they're around a year old, and you can tell a lot by them. So the anterior is the largest, closes at 2 years, and you're able to see if they have increased cranial pressure, if it's like bulged out, and then if it's like you can like go through it and it's like very sunken, then it would be dehydration. And then we go to the names and orders of the cranial nerves, and the mnemonic is OOO, to touch and feel very good, velvet, such a heaven. So we have number 1, which is one nose, 2 is optic, 2 eyes, 3 is oculomotor, 4 the trochlear, 5 trigeminal, 6 abducens, 7 facial, 8 vestibulocochlear, and then glossopharyngeal is number 9, 10 is vagus, known as the wanderer, and then we have accessory, which is basically like SCM and traps, and then hypoglossal. And then to know if they're sensory motor or mixed, we have the saying, some say money matters, but my brother says big brains matter more or most. Depends on who you ask. I don't really care about the mnemonic, to be honest. But basically, sensory, you have the olfactory, which is, you're smelling. Optic, which is when you're seeing. And then vestibulocochlear, which is more for hearing and balance together. Kind of like two separate branches that they just combine into one. Motor only, oculomotor, it's in the name. Trochlear and abducens, those are strictly for the eye. And then you have accessory, which again, we talked about the traps, doing the shrugs, and also the SCM, turning a little bit. And then the hypoglossal. Who cares about that right now? Not me. And then we have mix, which is trigeminal, facial, glossopharyngeal, and our favorite, vagus. And then we have the exit foramina for each one of these. And so for the olfactory, it's the ethmoid. And then for the optic is the optic canal, oculomotor, So 3, 4, V1, and 6 are all through the superior orbital fissure. And then for V2, we have rotundum, mandibular, V3 is ovale, and then facial and vestibulocochlear are together through the internal acoustic meatus. And then after that, we have the glossopharyngeal and vagus, 9 and 10, going through the jugular foramen. And then apart from that, we have the spinal accessory, also through the jugular, but also has like some foramen magnum, which is like the big hole, kind of like involved in that. It kind of goes dips in and out. I don't know how to explain it, to be honest with you. And then the hypoglossal canal, which just hypoglossal goes through it. Then other things that we should make sure to know is that the middle meningeal artery passes through the foramen spinosum, which if we go back, we would be able to see that spinosum just has that because it wasn't involved with anything else from the cranial nerves. It's just for the artery. And then we have lacerum, which doesn't have anything going through it, but it marks the bend of the internal carotid artery. And the carotid canal through what has it? It has the internal carotid artery passing through it. Then we have the jugular foramen, and it's important to know that apart from 9, 10, and 11, we said that the internal jugular vein also passes through it. For the foramen magnum, we have a bunch of things going through, including 11 again. That's more for the spinal root. I don't know if I care about that. Then we have more stuff here, such as the mnemonics for the jugular foramen ones. I don't really care about that. But it's, again, 9, 10, 11 in the meningeal branch of ascending pharyngeal, jugular vein, occipital artery, and emissary vein, which we'll talk about. We'll talk about emissary probably a little bit later. And then for the cavernous sinus components, you should know O, Tom, Cat, which is oculomotor, trochlear, ophthalmic, maxillary, abducens, and carotid. And then for the functional component summary, not my favorite. This is the biggest nightmare of all time. So we start with SSA, somatic afferent. So if I break it down for special versus general, so special is like just cranial nerves, then general is just everything else. Somatic meaning body wall, and then visceral meaning organs. And then afferent, remember like when they used to say like away, and it meant sensory. And then we had the efferent, which was motor. SA, we had the hearing and balance, because that's as special as you can get in terms of senses. So we know that we have 2 ears, so 2. And then the other one that has to do with that is the vestibulocochlear, and that's number 8. And then SVA, which is special visceral afferent, which means that it's also another sensory one. And it's special. So we have, and that's more like, more body wall, so more organ. The other one was body wall. So what organs do we have? We have the tongue, and we have more smell. So number 1 was olfactory, that was smell, and then taste was 7, 9. And then SVE is more for the pharyngeal arch muscles. I don't know how they came up with this. Some embryologists probably just wanted us to get more confused. And we have to remember that it's 7, 9, 10, and 11. 9, 10, and 11. And that is SVE, visceral efferent. Now moving on to general, we have general somatic afferent, which is body wall sensation. So that's general feeling on the body wall. It just says 5 mainly. Like to me, but whatever you say. And then we have GVA, which is general visceral afferent, which is organ sensation. So that would be 9 and 10 mainly. And then GSE, general somatic efferent, which is telling the muscles what to do. So we have 3, which is oculomotor, 4, trochlear, those are I1, 6, abducens, another I1. And then we have the hypoglossal, which mainly has to do with the that we have GVE, general visceral efferent, is mainly parasympathetic motor. So 3 oculomotor, and facial, 9 glossopharyngeal, and then 10 is vagus. How can we make sense of that? Say like if GVE is parasympathetic, I guess you can close your eyes with oculomotor, or would they like move more? That's a good question. Maybe I should have studied more before I started recording this. And then facial, I guess you can do a lot with that. But one there is that no nerve has all components, but no mixed ganglia. So we'll talk about more of the ganglia between sensory and motor later on. And then I attach this YouTube link. Please click it, take a picture, and it goat. The extraocular muscle innervations. Nobody cares about. Don't care at least. But I guess O4, LR6, everything else 3. That's how you see like what controls the eyes. 4, superior oblique is controlled by 4. Lateral rectus is by 6, and everything else 3. And we move on to this, the parasympathetic motor. So basically, how do we do some things? So the best thing is this mnemonic right here that they mentioned, which is COP. So you have ciliary, otic, ergopalatine, and submandibular. They're obviously not in order from top to bottom, but this makes things a lot easier in my head. I know they're going to ask some stupid question about it. Let's start with ciliary. So ciliary's preganglionic nucleus is the Edinger-Westphal, and it's found in the midbrain. And ciliary, you have to think about the third cranial nerve, which is again oculomotor, and then they have the sphincter pupillae and the ciliary muscle. Ciliary muscle has to do with like sedation and things like that. Then we have the pterygopalatine and the submandibular, which are both preganglionic nucleus is the superior salivatory and the pons with facial, and then you can see for pterygopalatine is more lacrimal, nasal, palatine, pharyngeal glands as their postganglionic targets. Submandibular is more of the submandibular and sublingual glands. Otic's preganglionic nucleus is the inferior salivatory on the medulla, and with the glossopharyngeal, the target is the parotid. I feel like they can single this out fairly easily. And then the intramural with our favorite vagus, and that's number 10 for the thoracic and abdominal organs. That was long. That was way too long. Swear to God. Sensory ganglia, trigeminal with trigeminal. We have facial with geniculate, and then we have vestibulocochlear with vestibular and cochlear, also known as scrappas and spiral. And then we have glossopharyngeal with superior and inferior ganglia, and then vagus with superior jugular, inferior slash nodos. I don't know how they say that. Anyways, now we move on to some more fun stuff because that was all. The dura mater, which is the outermost layer, named after Tough Mudder, I guess. And it has two layers, the periosteal and the meningeal. Then we have the arachnoid mater, which is avascular, which is in the middle. And then we have the pia mater, which is the brain surface. So in terms of the naming, I like to say DAP, DAP, so dura, arachnoid, and pia. Then we have the different spaces. So we have the subarachnoid, which is a real space. Deep to the arachnoid, it has CSF. It's a real place. While the subdural, right under the dura, between the dura and the arachnoid, potential space. So people only have it when they're like, sick of something. And then we have the dural enfoldings, which we have the false cerebri, which like goes through in the middle between the cerebrums. And then you have the cerebellum under it. It's separated from it with the tentorium cerebelli. And then separating the cerebellum, we have the false cerebelli. And then there's one more dural enfolding that I think is like very random to just throw in there, which is which is mainly for the sella turcica and the pituitary gland that it houses. And then the dural venous sinuses, we have this flow pathway between the superior and inferior sagittal sinuses going to the straight sinuses, and then to the confluence of sinuses. After that, we have the transverse sinus going around like here almost. And then sigmoid sinus, which is the S, and then internal jugular vein. That's kind of how it goes. So we can go through it here. You can see the false cerebri. You can see the confluence of sinuses. That's where the false cerebri also meets the tentorium cerebellum, or whatever you call it. Sounds like tortellini to me. So yeah, as good as it gets. And then you should know that you see the straight sinus meets the other sinuses at the confluence of sinuses. That's where like they all meet. So here's a cadaver thing that they showed us. So we have the white. If you look at the white, that's the cerebri, and then the pink, that's the tentorium cerebelli, tortellini. And then we have the red arrow, which was the superior sagittal sinus. The green arrow on the right here is the confluence of sinuses where they all meet. Then you have the one going to the side, which is the transverse sinus. And then going inside as an S is the sigmoid sinus. And then we have more venous drainage. So we have the superficial ones, and we have the deep ones. For superficial, we have the superior cerebral veins, the superficial middle cerebral vein, and the inferior cerebral vein. I don't care. More internal cerebral vein, basal vein, Rosenthal, great cerebral vein of Galen. I don't care. Yep. Emissary vein, only thing you gotta know is they're valveless, so they don't have valves. It can be pretty bad. And then for the dipolic veins, I don't know what they do. If, had a gun to my head, I wouldn't know. I don't know why you should know either. I don't plan on knowing. I should know. I might fail my exam. Danger triangle, again, there's two main roots where it's like angular, ophthalmic, and then like around here, and then goes in, and then to the cavernous sinus, and then there's also like facial, deep facial, this pterygoid venous plexus right here, emissary veins, like we said, it's the valveless ones, and then to the cavernous sinuses, and that's why spread of infection can be bad. And then again, the final common pathway is like you have these dural sinuses, they go through the sigmoid sinus, and then they drain into internal jugular. You go brachiocephalic and then superior vena cava straight to your right atrium and your heart. So that's how it kind of goes down. Then we have the meningeal hemorrhages, which can be pretty bad actually. We can start with the one they like to ask about, is the epidural hematoma, which is between the skull and the dura. And that's with the middle meningeal artery. So it's arterial. And usually you would have some sort of like bad trauma, and then it would go like that. And then we have the subdural hematoma, which is venous. And that's right under the dura, between the dura and the arachnoid. That's why it's a potential space when it's only bad. And it usually happens with shaken babies. So if they're shaken and you see like there's something wrong here, it might be from that. Make sure they go to the hospital, please. And then we have the subarachnoid hemorrhage, which is a aneurysm rupture. And the space is filled with CSF, which is the subarachnoid space, known as the thunderclap headache. There also were some findings of like CT appearance and things like that. So for epidural hematomas, it's mainly like a lens. In the CT, while subdural hematoma is more, crescent shaped. That's more, if you're reading CTs day in, day out, honestly, like it should be more emphasized, in my humble opinion. And then we have the cerebrum, brainstem, cerebellum. No one cares. Yep. Then we have the cranial nerve nuclei in the brainstem. So we have the midbrain, which is 3 and 4, pons, which is 5 and 5, 6, and 8. And then we have the medulla, which is 9, 10, 11, 12. Dang, these Roman numerals, I don't like them at all. Let's kind of skip these. I don't really like these. I don't know about you, but if you want to read it, read it. Okay. And for the fun part is the one that every time I learn it, I have to relearn it. But basically, we have the anterior cerebral arteries. So this is for the cerebrum, and then between those two, we have the anterior communicating artery linking them together. As we go further back, we always have our anchor, which is the internal carotid artery, being the start of the show here, and then branching out to the middle cerebral artery. And then what helps connect the posterior cerebral arteries as we go back to the front is the posterior communicating artery, which is kind of weird because that doesn't happen in the front. Anyways, enough with the cerebrum. Let's see what the cerebellum got for us. So we have 1 superior and 2 inferiors, is what I've heard. So we have the superior cerebral artery, and then as we go back, we have the basilar, and then as you go back, you have the anterior inferior, and then further back, you have the posterior inferior. So two posteriors. She emphasized that 2 posteriors, 2 inferiors, 1 superior. Then we have the vertebral arteries just hanging out, and then the anterior spinal artery as the zipper. And then this is a recap of everything. I hope you don't learn anything, because I didn't.